Canadian guy, speak, Paul Winston. Paul, you have to show your socks because it seems really that you are the only one who adopt the concept of snow for snow Congress.
Yes.
So really, you are the winter guy.
Thank you.
Let's thank you to present your work.
Sure. Thank you so much. I'm just going to take a moment before my talk. We decided when we created Canosk, we wanted to explain what Snov and Grenog does, but to the world. And one of our goals is to have people from developing countries, so we get a lot of people joining from around the world because everything's free. We created the Leap de Normandie prizes for we want people in training to submit manuscripts and get published. And we decided to launch 2 prizes. And they're for $1,000 Canadian, which is less than American, but it's to cover your cost to the conference and accommodation, and we are accepting awards. So there are 2 awards that we have, and it involves a manuscript or essay that you can submit. And this year, we were really pleased that a really wonderful submission came from Cameroon. And we are really delighted that the team of Dr. Symphorien Kambou and Dr. Michael Tamgoa presented a beautiful paper on how they are trying to start, as a neurologist and a physiatrist in MPR, a program in Cameroon to introduce neurologic and stroke rehabilitation. So Marjorie, can you stand up? And I would just like everyone to clap for them so we can send this video off to Cameroon. So if you can turn around. And Great. Félicitations. And they will be presenting in January, and they prefer to do it in French, so we'll do it French with English translation. Thank you. Okay, thank you. I'm going to move on. The way that I've decided to explain to the rest of the world, because you only write in French, none of you publish in English, these idea of motor nerve blocks and concepts, was how do we get this message around the world? Because I had to learn how to do motor nerve blocks after you taught me, because there was nobody to teach me in Canada. But we went to ultrasound. But I really want to thank Nadine, because without Nadine, I send her hundreds of emails and texts, often at 10 o'clock at night for the morning. How do I do this? What do I do? So I would always send Nadine videos, and Nadine would tell me what to do. And I'm really grateful to Nadine for showing me around the operating theaters in France where I learned where the nerves were. So I started off learning about motor nerve blocks 5 years ago from the master, and it was very hard for us to even just use the same H reflex with our EMG machines. None of the needles connected, so it was very difficult. And then Marjorie said, just use a clavis and you'll be okay. And then I discovered this paper by you, and this was the first time that I learned about muscle selectivity, because nobody in North America was really talking about this in a didactic way with nerve blocks. And then you went ahead and published this beautiful guidance, but at the very bottom, you said, there's no evidence that there's a superior effect of ultrasound. However, all of our anesthesiologists and radiologists prefer ultrasound. And then you did this beautiful atlas book. So you have given me all the tools, and we decided to learn it with echography. Now, my inspiration as well is the Yost Atlas, published by Quintessence, which is probably the nicest book for anatomy. So we've decided to publish with them, so they've agreed to publish our atlas. So we are creating an atlas by many of you in this room are authors, and it is to improve your efficiency of botulinum toxin injection, how to localize, how to do surgery, how to distinguish between a muscular tendinous retraction, a fully reducible deformity, so that you can do toxin, you can do phenol, you can do surgery, you can do tenotomy, whatever you need. This book will show you how to localize for ultrasound procedures. So we will be going through all the main muscles of the body with the ultrasound labeled. Here would be the latissimus dorsi. This is just my mock-up. This is not the final version. And it shows you what it will look like with the nerve. And going through each of the nerves, and you can see there's an approach, say, for the musculocutaneous to brachialis from both the medial and lateral approach. Now, ultrasound scares everybody who does not do ultrasound. The key factor is, however, once you do ultrasound, you only have to look for the blood vessel. So I'm just going to point out who are the amazing people who've been contributing to this book. A lot of you are here. And a bunch of people from around the world have been very generous with their time. So one of the things that we do know from this lovely paper including people in this room, is that a quarter of physicians feel limited by how much toxin. So the part of the book is how do we maximize our treatments for patients. But nobody in the world outside of probably France and maybe Italy really have used this term before, reducible deformity versus muscular tendinous retraction. So I had to practice that a lot from Nadine. And I always say, how do you say that in French? I published my first open access ultrasound guided technique in American Journal of PMR, and it's free to look at. Now, this is what we learn when we learn nerves, right? We take a two-dimensional picture and we lay it on the arm and say the patient has this, which is absolutely ridiculous because nobody has this. And my nice colleague here from Salt Lake City showed me a nice chapter on all the different innervations of nerves, so thank you, Mark. But we can do better, and you can talk to Stefano Carta about this, but this is Axel Schramm from Germany. This is his 3D ultrasound tomography. So he is sending me all the images of 3D recreations of the nerves. So just to remember to people that you can actually see the branches and follow, and it's not just the distance, because you can follow how they track. So this is some of the different nerve branches that Axel has given me. But this is what it looks like. So this is Dr. Mark Mahan. Can you just raise your hand? Over here, he sent me this nice picture showing me all the different innervations you can have to the elbow flexors and wrist. It's a lot more complicated than I thought. So there's his different variant branches. Now, he sent me this image of the tibial nerve, which I love, and then Marianne Keenan sent me a text with this picture of her doing phenol in the same location many years ago. So I quite like that. Humans don't change. But this is what you need to know for anyone who's afraid of ultrasound. There's a big blood thing. It's called a blood vessel, and it's big and red. So you can turn on your Doppler and not be afraid. And you've all been injecting blind through the skin for years, not worrying about blood vessels. Now you see what you're scared of. So it's easy. All you have to do is find the blood vessel, and you will find the nerve branches coming off it. So in this case, it's an obturator nerve with the anterior division. We can go up to the pectoral nerve. So you see that there's actually a little blood vessel going in around the blood vessels, and you can see, that's my body at the top, you can see the pulsations. We can see the femoral nerve, we can see the branch, the rectus femoris coming off. We turn on the Doppler. And in the median and ulnar nerve, the blood vessel runs right next to the nerve along its course. So it's very, very easy to see on ultrasound. We can also watch our injections. So at the top, this is how I would inject lidocaine or saline or phenol to do a block, and you can see the location as you inject. It's very fast. It's much faster because you just put your needle in, you see it, and you inject. And there's an example of a gastric nemeus, 2 different injections with the ball of fluid. So you can make sure that you're actually touching your target. Here is an example of seeing the needle tip going in to the anterior division of the obturator nerve, which will go more towards your adductor longus and brevis, maybe. There's some multiple innervation. And on the bottom, you can see your brachialis. And you can very nicely see the blood vessels, the branch, the brachialis, and your trunk. For the obturator, you have 2 choices. We can do both the longitudinal view, where you see the blood vessel very well, but you can actually turn it to the side. And I call that the cake. So you have adductor longus, obturator branch, abductor brevis, and then abductor magnus underneath it. And you can see it very nicely. So as we go through the atlas, you will see each nerve at each level, how to do the biceps, how to do the brachialis. And this is a lateral view or medial view. Now, one of the complications when you start doing ultrasound, and this is my colleague Rajiv Ribai in Vancouver, Alessandro Pacelli, and Mike Munin. I'll just go back. You have the HECMAT score of fibrosis. So Ev Boissonneau, our fellow, is working on this. This is the young boy I showed yesterday with a biceps. So he's cerebral palsy. He's never had toxin. He did cryo, but his anatomy is very clear. This is the fibrotic woman that I showed in red, her arm coming up 17 years after. It's a snowstorm. You cannot see anything. But you find the blood vessel, you turn it on, you put your needle in, and you stimulate, and you can find the biceps. So even though that looks like a snowstorm, you can actually find it if you always find the blood vessel. Oh, hold on. There's no sound here. Is the sound on? The song?
You doesn't look very reassured, you know. But you see me.
Est-ce qu'on du son? C'est le gel avec chlorhexidine, alors c'est déjà mixte. Alors, so we would scan the biceps, the brachialis that way. And we can do the radial nerve very easily, so I really like this one for brachioradialis. It's very easy, it looks like a heart. And we can do the median nerve at multiple levels, but you can see how always the blood vessel's next to the nerve. So you're already doing it blind, so don't be afraid. So we're also making maps in the book of each level. So if you go above the elbow, you'll get pronator teres. If you just go a bit lower, you'll get flexor carpi radialis, FDS. Now, of course, you're going to have your branch into your anterior interosseous nerve, which is very small, so most people can't see it on ultrasound. So you'll probably come more proximal for it. But then you can go down to the towards the carpal tunnel for the intrinsics, either before or after the tunnel. We can do the same thing for, this is an example for the median nerve pronator teres, and it's very stereotyped. It's usually in the same place. This is an example of us doing a scan up and down the forearm. So we can actually track the median nerve, and we're going to look for it coming up, rising again, and it's right there. So you get very comfortable at watching it go up and down the arm. And this is another example. I'm going to spare you, Eve, of talking to not embarrass you anymore. But this is scanning the nerve coming down. And you can just look as she's coming down the arm. And you just watch the blood vessel, and you can see your nerve next to it. There's the nice, very strong blood vessel. So just right, the nerve coming down. Now, this is how we like to be very specific. So this is it's actually my resident stimulating at the level of the flexor digitorum superficialis, but you can actually see his needle is here and he's stimulating the forefinger. So we don't actually have to touch the nerve when you were talking about how approximate we can be, so we can just move the needle and get each finger move. And particularly in patients that are fibrotic, you might not get a nice stim, but with ultrasound you can see the muscle contraction, so you don't have to turn up high stim because we really want to stimulate the nerve for phenol or cryo. We don't want to stimulate the muscle. So this would be an example how we're using nerve blocks. Saw this patient with tremor. He had a truncal tremor, a head tremor as well. And we were in clinic and my resident said, why don't we just block him and see what happens? So we decided to watch his tremor, and we wanted to know if we could actually use blocks in this case. So she's doing a radial nerve block first because he had a lot of wrist extension, and you can see her going her target to the radial nerve. And then we followed up with a median nerve because he had a flexion component as well. So just next to the blood vessel, she's going to stimulate. And after we thought, oh, that looks pretty good, we actually did toxin to the muscles. We thought he was sick, so he didn't come for follow-up, so I don't know how he did yet. But he was actually quite pleased. His wife said he hasn't stopped tremoring like this in years, so I don't know if toxin is strong enough, but it was a good result for us. And because we could see on ultrasound which muscles were moving, it was very helpful. This is how we do the ulnar nerve. So again, the ulnar nerve is very easy to see next to the blood vessel. We use the same approach for cryoneurolysis. I really like doing ulnar nerve blocks at Guillaume's Canal. Nadine helped me with this a lot as well, because as you know, intrinsics are so hard to release. So we do a lot of blocks, comfortable with ultrasound at the ulnar. We don't hit the blood vessel, because I find you can really decide what might happen to the patient. So he cannot open his hand here on his own. So we are going to do a block. And after the block, he's said, oh, I can open my hand. So these are the cases where we never know what to do next. Do we just toxin the interossei because it's not strong enough? Do we do surgical release? And we put on a little bit of electrical stim just to help him out. Jörg Wissel's, one of my favorite papers, is the positions of the shoulder. In many places in the world, you don't have toxin covered for the shoulder muscles. I know Botox isn't covered in Europe for the shoulder, but maybe Dysport is, but not. I'm not sure. Everybody's different. But a lot of places you're not allowed to talk about the shoulder. And of course, these are the main muscles, so subscapularis, pec major minor, latissimus dorsi. So we can actually always get the lateral pectoral nerve. It's 100% consistent, and maybe Dr. Parra, you can tell me if I'm wrong about that. The medial pectoral nerve has a much more circuitous course, so it's hard to find, and it's deep. And when you see that heart beating underneath your ultrasound, you get a little bit nervous. So I showed these yesterday, how we can stimulate just the medial pectoral nerve, the pec minor, and we can do the pec major as well. And again, this is how we would do our assessments for the shoulder to see if we can just do the pectoral nerve. And in this case, just doing pec major for her cryoneurolysis was fine. And she's very happy, and she's about a year out, and she's just like this. And really good external rotation as well. We can do the rectus femoris, so there's the artery with the nerve coming out. Again, these top pictures are taken right from the atlas. We didn't redo them. And this is a famous photo that you all might know that we learned all of our landmarks from. Alessandro Pacelli added ultrasound to him. So we used Alessandro as well for our landmarks. And then we took this one we stole from you, and we added our own little headings. So we have all of those on the wall in the clinic. But this is how we do the tibial nerve with ultrasound. You can actually see the trunk is huge, so you cannot miss it. And what's interesting is sometimes the blood vessel is below the nerve, sometimes it's beside it, and sometimes it's on top. So when you stick your needle in, do you really know where the blood vessel is? So we always do it with ultrasound. Now, if we don't want to do the whole trunk, and we just want to do, say, the gastrocnemius, it's very easy to see the medial and lateral gastrocnemius. When you turn on Doppler, you see the blood flowing in the nerve. And we can just go down the leg, and we can get the soleus branch, we can get the tib post, and the FDL, flexor digitorum longus. And this is the branch to the tibialis posterior. Of course, we're doing stimulation, so we know we're in the right place. So this is an example of why we like ultrasound. So this is Dr. Boissonneau stimulating. She's just touching the tibial artery, and we're at a very low stim, and we start getting contraction. And then she just moves it a slightly more, and the contraction becomes more and more. So we can see it on ultrasound. And then we look at the patient, and we know we're just on the medial head of the gastrocnemius, because he's going medial. This is another example of the medial branch of the gastrocnemius, and you can see it so nicely with lidocaine. Oops. So oh, I lost the sound on this, but she's a woman, and she's saying, "It moves, it moves." She wouldn't stop saying, "It moves." She was so happy. She gained 35 degrees of active dorsiflexion after this. So one thing you were talking about, really, really happy with the change in range of motion. And this is, again, the branch to tib post and FDL. They're very close together, and that's how we stimulate them. Obturator nerve is now my new favorite after seeing it in the operating room in Lille, how vascular that is and the chance for bleeding and exsanguination. So we go in, you can very nicely see the posterior branch. So that's more to your adductor magnus and a bit of abductor brevis. And then you have your anterior division, which is where people often just target. But you can see I can very nicely stimulate the posterior branch and the anterior branch without difficulty. One needle in, do the first one, inject, go a little bit further. So you're avoiding all the blood structures. And if you bled, you would see the bleeding on ultrasound. And this is what I meant by the layer cake, comme une millefeuille. You can turn it sideways, and on ultrasound, it looks like muscle fascia, but it's actually the nerve going through. And this is how we would rotate if we're not sure. So I'm turning the probe back and forth. So you can see the blood vessels this way. And in this case, it's quite neat. The anterior division of the obturator artery splits in two. So it's going around the blood vessel. So we can target it there. This is Dr. Boissonneau doing a cryoneurolysis of the anterior division of the obturator nerve. And we can see it, so we're making sure we have contact. Now, once you make a ball, it sticks. It won't move. Even if the patient has cerebral palsy and is moving, it's like a horse. They're staying in place because it's frozen to the nerve. This was actually my very first nerve block of a patient that I'd never done operators before, and it worked quite nicely. This is how we do the femoral. So again, we turn on the Doppler to make absolutely sure we see our target and do our femoral nerve. And I just want to thank, I lost music again. I'd just like to thank Dr. Boissonneau for sticking up with me, because we try to, we have to laugh a lot because we don't have a lot of resources and it's just us. And so if you come work with me, you have to dance. All right. I don't know where the music went. So part of the purpose of this talk was people who are afraid to use ultrasound. It's never too late.
Do you have any question in the audience? When will the guide be ready? Your guide, your Atlas guide?
I'm waiting for like 2 submissions from a couple of countries in Europe, and then I'm done.
Okay. Soon, so?
Soon.
This year?
It's ready, just like
2022,
two chapters.
for sure.
Yeah.
Okay. What about the learning curve? Because when we look at you, it looks so simple, while I suspect it's not as much. Do you think we need to build a course for ultrasonography? Does it exist somewhere? What is your opinion?
So, I mean, I started doing it after I was here in 2017. I went home and I had to ask an anesthesiologist because nobody had the skill. So it's my anesthesiologist who taught me, who invented the cryo technique, because he said, oh, we're doing lidocaine blocks, why don't we just do cryo? So that's how we invented our cryo protocol. So it was the anesthesiologist. So you have it here in Europe, you have really great ultrasonographers right over here. In Switzerland, and Serdar Kocher, of course, runs an amazing course in Switzerland. So Serdar and I have taught this course. And Rajiv Ribai in Canada with Omar Khan, they teach an incredible online ultrasound course. And with COVID, they teach it online, so they could teach all of you as well. We could do this. Yes?
The Academy of PM&R in the US has a course for ultrasound. There is a musculoskeletal, and then there is a neuromusculoskeletal.
Yes.
Good to know.
Merci Paul pour cette présentation. Je vais parler en français cette fois-ci. J'ai 2 questions. D'abord, je ne sais pas quelle sera la forme finale de l'Atlas. Avez-vous prévu un tout petit peu des astuces, ce que vous présentez, c'est des membres en position anatomique, en coupe axiale, c'est ce que j'ai vu. Est-ce que vous pouvez présenter un tout petit peu des astuces pour les bras, les avant-bras très en pronation, comment se repérer? Est-ce qu'on peut éventuellement imaginer combiner la facilité le guidage de l'échographie avec la technique suggérée par Bernard Parat, donc l'orientation de l'aiguille dans certains muscles nécessitant des coupes longitudinales et non pas axiales. Donner toutes ces astuces un peu pour chaque muscle. Parce que là, on apprend tous, on voit tous les coupes axiales. Mais si on essaie de combiner, on identifie le muscle très bien, mais si on essaie de tenir compte de ce que Bernard Parat, avec ses travaux, a mis en évidence, l'utilité d'injecter d'une certaine manière, et parfois en plan longitudinal, les muscles, juste donner les images qui pourraient guider les utilisateurs pour ça aussi.
So yes, so the original Atlas is from Germany, so it's all these really big, beautiful bodies. We changed our models to have a bit of different skin color because that's what the world looks like in different ages. So the reason of the Atlas is to see what a normal non-spastic muscle looks like. And Dr. Rebai has written a section on HECMAT score. So in the book, you will see the different fibrosis. If you can find the blood vessel, you will find the nerve. So you practice on patients who are in good anatomical position. Once you know what it looks like, you will see it on everybody. So we hold each other down. So I will be sitting there with Dr. Boissonneau. She'll be at this angle. I mean, you're used to doing it, your nerve blocks, without guidance already. So you're used to trying to target. It's much easier in a out-of-plane patient like this because you could just turn on your Doppler, you find the blood vessel, and then you see the nerves to stimulate it. So we find it much easier in the patients that have dystonia or different positions because we look for our landmark. We know what the muscles look like. We know what the blood vessels. The shape of the muscle doesn't change. So it makes it easier for us.
With ecography, there is always a ask of price and a type of engine because it's, you need clearly a less powerful engine for tracking muscle than for tracking nerve, particularly for distal part of nerve. And you are really a special engine. Could you give the trademark of the
Sure.
engine and the price of engine?
So the machine that I got is because Alessandro Pacelli has it. It's Italian, and it's an Isoete. Do you have that as well? Okay, it's an Isoete. That one cost us about 30,000 euros, so it was not too bad. The hospital, I had to wait 4 years to get a machine for my hospital to pay for one for me. So that is a barrier because they don't pay you to do ultrasound guidance, but your hospital should pay for it. So most of the new ultrasound machines will do nerves very nicely. You don't have to buy a high-tech one because we really want one setting, and you just get them when they install it to maximize it. The automatic setting is musculoskeletal, and that will do nerve very nicely. You don't want abdominal.
I should add to that now really the machines have gone down in price substantially, and some of the portable machines which have high quality, pretty good quality, can cost you less than 5,000 euros. So there are nice machines that you can carry around. You can.
Yeah. Ask Stefano. He's a very good ultrasonographer.
So, thank you, Paul. We are waiting for your atlas, and I would like to have a personal dedicace when,
You will.
when I will buy it.
But you have to sign your copy of yours.
Okay.